Namaste. My name is Vishnu Sapkota. I would like to invite you all today to this webinar series organized by American Nepal Medical Foundation in collaboration with Nepal Medical Association and NMSS. Um, the objective of today's talk are to highlight the challenges faced by surgeons in providing much needed surgery in Nepal. How can we try as patients and provide services to the most needy ones? What is the role of preoperative testing? What are the precautions we need to take during the surgical procedures and post-op care? We have a list of highly esteemed speakers today. We have Dr. Anil Bikram Karki, who is the senior head and neck surgeon who practices at BP Korala Memorial Cancer Hospital in Nepal, who is also a vice president of Nepal Medical Association. He is going to speak about challenges in Nepal in providing surgical care in current situation. And we have Dr. Dipesh Gupta, who is an associate professor of urology in Nepalganj Medical College. He's going to speak about how to triage patients requiring surgery during the procedure. And we have Dr. Sushil Raj Pandey, who is a senior colorectal surgeon from the United States, who is going to talk about the role of testing, preoperative for the COVID-19 before surgery, precautions to be taken during surgery, and what are the things that can be done in post-op period to provide safe care to the patients. So without further delay, I would like to invite you all once again to this ANMF live webinar series. And the topic of today is impact of COVID-19 and surgery. So Dr. Anil Bikram Karki, please go ahead and give your thought and presentation about challenges in Nepal in providing surgical care.
Dr. Vishnu, good evening and good morning in the US. Basically, we thought of doing this Zoom meeting so that what to do and what not to do. There is a big chaos in Nepal about surgical field, medical field everywhere. So by the end today, we hope we, from the chaos and confusion, we go to conclusions and confidence. I'd like to start with the guidelines by Nepal government for surgical procedures that require general anesthesia. So they have kept in two groups. One is life and limb threatening condition, which is highly suspicious of COVID-19. And they have recommended PCR and RDT if available. But we don't wait for test or results, and we proceed with surgical procedure with proper protection.
Dr. Karki, is it possible to make it like full screen? Can you start?
Okay, sure.
Sorry. No, the click the slideshow at the top. Slideshow. Yeah. Yeah.
Okay.
So thank you.
For elective cases, they say conduct RDT, and if negative, proceed with surgery procedures. If positive, do a PCR, and if it is negative, we proceed with surgical procedure. But if you look at the international guidelines, they say a big no for elective surgeries, and the role of RDT is also quite confusing. So the present scenario is like in Nepal, there is a big confusion on do's and don'ts, what to do and what not to do, where to operate and where not to operate. And there is no proper guidelines by any surgical societies, or like we still don't have a national guideline kind of thing. And of course, there is lack of proper testing at proper centers, and lack of equipments and everything like for the surgery. And there is a big gray zone of like what is emergency, what is semi-emergency, and what is elective. And the big factor among all health workers, like there is a fear factor, and there is of course pressure from the employee that we should be operating, we should be seeing patient, be it government, non-government, private, semi-private, whatever. And there is also the pressure from service takers, because like earlier we used to operate wherever we could, whenever we could, however we could. But now, since this COVID-19 has come, we are avoiding elective procedures. So the patient, of course, have a big question. If yes, then why not now? So these are the factors I think that is more or less dominating the playground today. And if you see my center scenario and my team, we used to do on an average 117 cases uh, at the just before the month of Fagun. And now in this Baishak, we just did 2 cases. That is also emergency tracheostomy and one bleeding case. So this is because we were avoiding cases, and of course, due to the lockdown, the patient that were coming also were less. But now we still are moving towards normalcy. And if you see most of the cases, different units, they have the cases have gone down. And of course, the extended hospital service, it's a big zero because Nepal government has said stop it. So we have been stopping, following the government's guideline. So I feel we should have something concrete at the end of the discussion. So I feel if we could follow this 5P, it will be easier for us to work. Uh, so you should have a perfect plan, like what you are going to do, what you are not going to do. You have to have a preparation. You have to have sufficient procurement, and of course your protection, and then only we can proceed to the surgery. By plan, I mean from pre-op preparation, like we should have a detailed workup. In fact, because now OPDs have opened up and we are seeing patients from different parts of the country, which is very challenging. And the second challenge is if we also follow the media and social media is like social distancing. And the most important part, but the most confusion part is always the history, because most of the patient they feel that if they give a proper history, then they will be sent to test for COVID, and then they will have to stay in quarantine, and there will be a social stigma and all that. So, but still, we have to insist on travel history. Now, for Nepal, it's like all those districts in the red zone. We have to take a proper fever history and contact history, and of course, the geographical area. And for emergency, if we have the facility, we can just send for PCR for emergency and semi-emergency. And of course, we don't wait for like the courts, but we should have a team plan also. At least we should have 2 teams so that one team operates and another team can be there for backup. And the safety of the team should always be a priority. And for resource, if you have multiple resource, like what we are doing here in my center is we are keeping one theater for emergencies and one team for doing without PCR reports if you have any emergency. So that tomorrow, if by any chance we have a COVID positive patient without proper PCR testing, then we can isolate the team, which would be important in further management. And of course, you have to manage your time and the cases so that you don't get too worked out or too exhausted. And preferably, I feel we shouldn't promote doing elective cases till the curve goes down, and see what you have in stocks. And the another big factor we are facing in Nepal as of today is of blood products. Uh, every day, the collection has gone down because of the government restrictions and the social restrictions and the lockdown. The program, those blood donation camps have been reduced quite significantly. So at times you don't get even whole blood and other products. So prepare. The most important preparation, I think, is the mental preparation among the hospital staffs, the teams, and you have to assure that you have taken whatever precautions you could do, and emotionally, so that the fear factor goes down. If we could prepare the team and their families, I think the half job is done, because ultimately we have to work and we have to be safe. So after that, I think we should prepare our patient and patient party, because most of the patient, they think, okay, we have done PCR few days back, so we are like immune. But there is every chance that you could get it positive in the post-operative period when your immunity goes down, or you could contact from other sources within the hospital also. And we have to prepare all staffs. By staffs, I mean from minimum wage workers to the team experts. So whatever you can procure, like masks, gowns, face shields, shoe cover, gum boots, we have to, if we can, and something we can like produce locally. Like now in Nepal, the aerosol boxes have been uh, produced locally, and if we have, I think it's better to have video laryngoscope for quick intubation. But since in the market there are not much, I've seen few centers in Kathmandu, they have developed their own, and whatever you can, we can buy. If we can't buy, we can autoclave and use it. So ultimately, it is like you protect yourself and you proceed forward. So we should take safety every level. We should be precaution for all staff. It is not only for like doctors or nurse or paramedics or whatever. Even from the cleaners to visitors, everybody have to maintain that safety. And we should proceed so as to minimize the surgical time, blood loss, whatever contacts we get. And I think the main goal is we shouldn't be overconfident so as we avoid safety precautions, which I see is happening nowadays in Nepal because of so many people are getting crowded and everybody is thinking, okay, COVID, we have the BCG factor and what. But still, whatever we can, we should take safety measures. So I thank you, everyone. And this is our team post-COVID. We have been operating oral cavity. We have been doing tracheostomies, high-risk surgeries. Hopefully, us will do fine. Thank you.
Thank you. Okay. Thank you, Dr. Karki, for your short and sweet presentation. Viewers out there, if you have any questions, please feel free to text those questions via the Facebook page, and at the end of the session, we are going to address your question as much as possible. Now I'm going to invite Dr. Dipesh Gupta from Nepalganj Medical College to highlight on how to triage patients requiring surgery during this COVID pandemic. Dr. Dipesh.
Yeah, good evening, everybody. Can you see the slides? Yes? Yes. Okay, so I'll be, thank you very much. I thank ANMF and NMA to give me this opportunity to speak over here. So my NMF friends are there who are doing very great job bringing all of us together. So just to focus on few points in the surgical fraternity, I would like to focus few things. Like if you see the scenario as of today, so 402 confirmed cases, so probably many of that must have been added by today's data, and I heard it was the third day today. So what is the problem? We see the emergence of the condition of this crisis, which disrupted non-COVID-19 healthcare services as well. And we had to see so much of jeopardization of this ability of medical systems to respond to routine patients' needs. So that was the problem. So what was the need of the hour? So surgical departments, as a surgical fraternity, we had to respond by minimizing or temporarily suspending scheduled elective operations without any doubt. And simply, the aim of the strategy was to address the crisis by increasing health system availability to prepare and respond to the epidemic without becoming overwhelmed. So we have to prepare for so many things, as we saw in many countries what was the condition. So we had to prepare accordingly. So it prevented overcrowding in OPDs and wards, and probably prevented cross infections. So our plan of action was to prepare for this situation, to postpone elective operations, develop a plan, educate all, decrease exposure, and develop a dedicated operating space in the meantime so that we could tackle the situations which were coming as an emergency. So this slide just summarizes few things, like whatever patients were scheduled for surgery, like elective operations, how we dealt is like on priority assessment basis, we had to prioritize the patients. So we could do that by phone screening or screening by some methods so that we could see like which cases needed more attention, whether the patients were symptomatic or not. So if the patients had some sort of emergency and if positive or negative based on COVID test, so probably we could go ahead accordingly. And if like there was no symptom, like there was no fever, still if there were some few symptoms, then we could. So this summarizes few things which could help us plan the things. So levels of priority. So different guidelines, different international guidelines came up in the meantime. So which prioritized the patients whether to operate or not. So we had to see, is there any impact of delay on primary outcomes? Like in oncology, we could not delay much. Like there was the risk of metastasis, kidney failure in transplant patients, for example. Similarly, did we have any possibility of alternative methods in few instances so that we could hold the operations for the timing? Was there any presence of comorbidity? Was that a threat to patient's life if the procedure was not done? And was that a threat of permanent dysfunction of the organ system if the treatment was not performed? And the risk of rapidly progressing severe symptoms that could be time sensitive. So based on all these things, probably we could prioritize the patient. So all of the surgeons, I believe they must have done this. So different triaging systems came up. Like when I talk about mine, like being a urologist, when I talk about urological association guidelines that came up for this, especially for this pandemic situation. So low priority and intermediate priority and even emergency conditions. So they could list different disease conditions, like what was of low priority, what was of high priority. So if the postponement of condition, probably if that not hampered for more than 6 months, probably that was of low priority, and accordingly, as we could see. Similarly, other like American College of Surgeons, they also went for like this elective surgery acuity scale system. Different task systems was developed, which stated from low acuity to high acuity, whether to postpone surgery or to not postpone the surgery based on the condition. So different guidelines came up in the meantime, which could help us how to go about the cases. So main thing was acute case management, mainly emergency cases. So there was also debate like whether to treat emergencies differently. Like few of my questions were like even like in the case of acute appendicitis, are we going to treat acute appendicitis differently for the time being? Especially like we used to have some option of conservative management previously, which probably meant that this was the first line of management for the time being, placing conservative management. If we used to go for hot coli previously, probably nowadays we are going for more of conservative treatment for the time being. So it may be very variable according to the surgeon, like what has been his or her practice. So we can decide accordingly. And what is our local practice? So when I talk to so many of my friends who are doing their jobs in periphery, I came to know that they were even doing elective surgeries. So that depended on their local situation, actually. If my friend in the US, say, if he is not touching any elective case, but like here, they are doing elective cases, some of them, not all of them, like institutional or government services, they are totally shut down for elective operations. So again, the point is, which one is elective and which one is emergency or which one is semi-emergency? So these all, there is no definitive criteria. So that is sometimes, that depends on persons, like the patient's perspective. From surgeon's perspective, things may be different. For one surgeon, it may be a semi-emergency case. For one surgeon, it may not be one. So like even in emergency cases, if we see for this journal, which has very well come up with different, like from start, right, start from the transfer of the patient to the recovery room, how to go about tackling a case with COVID. So my other colleagues will be highlighting on all these points, like how to go about all this surgical management, how to manage these things line-wise. So again, another point is, my concern is local resumption of elective surgery. So when can we go for that? So even American College of Surgeons, they have also thought of this, like for surgical guidance, elective surgery guidance, they have come up with few guidelines, like you have to have awareness among the community for the local society. What are your COVID-19 numbers, including prevalence, incidence, and isolation mandates? So you have to know your own locality. How is it going? Are you prepared for that? Are you prepared as so far as your beds, ICUs, ventilators are concerned? If the cases come up, if more of outbreak is there, so can you tackle that? Patient issues, are you counseling the patient? Can you do proper counseling to the patients? Can you take the patients into I am regularly now counseling that there are still chances of in-hospital occurrence of this COVID infection. And similarly, no doubt, delivery of safe and high quality care service will be of utmost importance to us. Until proven otherwise, treat all as positive. That should be the dictum. So that's why we have been fighting for pre-operative COVID testing as well. As Dr. Karki said, there are a few guidelines that has come up from MOHP, but that is not sufficient for us surgeons, as we think that all pre-operative patients require the guideline and the testing. As we could see in Mumbai and in other situations, even in Europe, we could see that lack of testing that led to emergence of so many healthcare workers that became to be positive, and then the hospital was seized. Like we can see even in Kathmandu, in our local places also, when the healthcare workers, they became positive, it became havoc, and even the surgeons and the team, they had to be sent for isolation. Who was there to be operated? Who was there to operate now if the situation like this comes? Like we know, there are so many asymptomatic cases coming up, like in Nepal's scenario, 80% of the cases, more than that, they are asymptomatic or with very mild infections. They will go unnoticed. You cannot
Did we lose Dr. Gupta? Vishnu?
Yeah, we lost Dr. Gupta, looks like.
So he will rejoin it. Why don't we move ahead with Dr. Pandey's presentation?
Okay, so sorry, viewers out there, I want to apologize first because I think we lost Dr. Gupta here. But he did elaborate in very detail about the how to triage the patient for surgery. And for all of you, I just want to tell you that all this session will be recorded, so you can view this later on at your leisure. Now, I would like to invite Dr. Sushil Pandey, colorectal surgeon, who is going to talk about the role of testing pre-operatively for COVID-19 and precautions to be taken during surgery and post-op period. Dr. Sushil Pandey, I would invite you at this hour.
So can you see my screen?
I think it's still showing up something else. So can you click that COVID PowerPoint?
Yeah, that's what I am in here.
Maybe.
Okay, let me see.
Yeah.
So should I go in the application window, right?
Yeah.
Or entire screen, application window, okay. Okay, I think can you see now?
Yes.
Good evening and good afternoon, everybody. Good evening and good morning. Thank you, Vishnu, Santosh, Anil, and Dipesh. Today, I'm going to talk about COVID-19 pandemic and surgical care, mainly the testing and the pre-op and the intra-op care. The source of my presentation are from American College of Surgeons, American College of Colorectal Surgeons, SAGES, and European Association of Endoscopic Surgery, and others. So whenever you manage any patient, suspected or any other patient in current situation, is a partnership. It is a partnership between the patient, family members, doctors, allied care, healthcare workers, ancillary staff in the hospital, and the community as a whole. It is the greatest equalizer in the history, because even if you have a doctor, nurse, you have a millionaire, billionaire, poor, everybody can get it. So we all have to work as a team. So my first thing is, like, when you have a patient with a suspected or confirmed COVID-19 patient, should you do surgery or not? If there is no emergency, always postpone the surgery unless the patient is clear from the infection. That is the key. If the patient is emergency surgery, or if you need to have done, take all the precautions. So there's a few key aspects of COVID-19 surgical patient management. So these are 2 slides. I'll take a little longer time for these 2 slides. Now, first, all suspected or infected patient must be managed with maximum attention. Even if you have a testing done, sometimes there could be a false negative report. So all the suspected patient or infected patient should be managed with maximum attention. We have to make sure that we use PPE as much as possible and if available. Whenever we transfer the patient in the hospital from pre-op area to the OR to the ICU or floor, make sure that it is protected. You need to be very careful, otherwise on the way, the patient is very contagious and it might transfer to other patient or hospital staff. If you have a proven patient who has a COVID or highly suspected patient, you have to move as little as possible to the hospital, because more you move, more exposure you give, there's a high chance of transmission. And in any hospital, the transfer route for the COVID patient has to be well planned, precise planning, and as short as possible. So make sure that you have a drilling in the hospital, how you are going to move the COVID patient from one place to other place. In the operating room, you should have a separate area for the COVID patient for the surgery. And the operating room should be as close to the entrance door as possible so that you don't travel too much in the OR. While taking care of the COVID patient, use disposable material as much as possible. And whenever you transfer the patient from one place to other place in the hospital, you use same transport person, because the more person you use, there's just multiple risks of having a transmission. So use only the same person. Once the patient is in the OR for any procedure, make sure that all the OR doors must be closed, because COVID transmitted by the aerosolization, so there's a chance of transmission in the OR. So close the door as soon as the patient goes in the OR. Whenever the patient with the COVID or suspected patient is having a surgery, all the OR staff has to be entered in the OR in timely fashion. When the patient is being intubated, all the staff may not need to be in the OR, so they can get out. And once everything is done, they have to enter as they are needed. Whenever any patient is being performed, surgery is being performed, any procedure, make sure that the people in the OR don't leave the room too frequently. Leave only is absolutely necessary. And we have to use high OR air exchange system in the OR just to circulate. And all the documentation, all the administrative stuff can be performed outside the OR, because just to have a minimum exposure. At the end of each surgery or a procedure, all the disposable material must be disposed, and all the surface and all the surface of the device has to be cleaned and disinfected. PPE must be removed and disposed outside the OR in designated area. And after the end of the surgery, all the person involved in the procedure or surgery should take a shower if possible. Whenever you extubate the patient, the recovery of the patient, it has to be done in the operating room before you transfer the patient to ward or ICU, because you cannot mingle the patient with a regular patient in the post-op recovery room. So these are the few key aspects of COVID-19 surgical patients management. So what is the risk of contracting the COVID-19? Sometimes the patient may ask you, hey doctor, what is the risk of me having a COVID-19 when I came in contact with other people who has a COVID? It depends upon a lot of factors, like what is the prevalence, how sick is the patient, and how long was the contact. On average, the estimated risk was 0.45%, the risk of contracting the COVID-19. So at this point, like all the elective surgeries being postponed or canceled. So the next thing is when do we start doing the elective surgery? You know, we always think of elective surgery and emergency surgery. There's a lot of in between elective and emergency surgery. And depending on the situation of the patient, it may move towards emergency or elective. So there's not a book answer, which is elective, which is emergency, and which is in between. But in general, what are the elective surgery that we should be performing? That depends upon your hospital. Look at the prevalence of the hospital, look at the admission rate, look at all the manpower that you have it, and all the supply that you have it in the hospital, if it's sufficient or not. So for the surgeon, the approval from the hospital or surgical center is needed to start the elective surgery. And the person who makes the decision for the hospital, they always should follow the recommendation, either from the CDC guideline or the local health authority guideline, because the guideline can be different from one country to the other country, or even the same country. The guideline can be different from the different part of the country, because it depends on a lot of factors, like what is the readmission rate, what is the incidence, incidence is declining or not. So there's a lot of factors that come into play to make a decision. So now, what is the role of testing for COVID-19? Should you do all patients who are going to have a surgery for the COVID? Yes. Right now, there's a lot of unknowns. We don't know the complete pathogenesis of the patient, and nobody knows exactly how it's being transmitted or how bad it is. So all the patients, we treat as if they are the COVID-19. So all the patients should be tested, yes. And don't always go from the symptoms. There's many patients who can be the silent carrier, and they can transmit the patient to other people and who can get sick. So we have to keep that in mind. So if the patient is being tested and it comes negative, should we still practice the same standard precautions during the surgery and endoscopy? Yes, because like I said, sometimes the testing are not 100% accurate. There's a lot of false negative reports. So we have to be careful. We have to take all the complete precautions in the surgery. Like during the surgery, like smoke evacuation, we use the filter, have a less exposure. Regarding the utilization of the PPE, see how much PPE you have. If you don't have sufficient quantity, so you use maximum. If not, use as you need it. So one of the important things for the patient with the COVID or any patient suspect of the COVID is intubation risks. As we all know, COVID transmits from aerosolization and the droplet transmission. So during the intubation, doctor, all the staff in the OR, they have very high risk of contracting the disease. The risks in the procedure like endotracheal intubation, tracheostomy, GI endoscopy, and evacuation of the pneumoperitoneum or aspiration of the body fluid during the laparoscopic surgery. These are all the high risk procedure for transmission. Whenever the patient is being intubated or sedated, all the unnecessary stuff has to stay outside the OR. Once the patient is intubated, you have to allow at least 20 to 30 minutes to settle all the droplets or aerosol in the air before they can enter the room. But like I said, these things can be modified depending upon the situation in the hospital. Always try to intubate in the negative pressure room. Not all the hospital has a negative pressure room, but you have to take a maximum precaution and modify it as you need. and make sure that whenever you take care of the patient during the intubation and all the high-risk procedure, use appropriate PPE. So do you recommend negative pressure room for all the patient? Most of the OR is the positive pressure. Intubation and extubation has to be in the negative pressure room. And some of the OR, they are not, some of the hospital doesn't have either of them. So you have to take a maximum precaution. If they have a separate negative room, intubate the patient, then you can transfer the patient to positive pressure room for surgery and extubate in the negative pressure room. So as you know that, the COVID-19 is transmitted by the, aerosol infection, but in the surgery, when you performing the surgery, what is the data that there's a risk of transmission? There's insufficient, we don't know exactly how this COVID-19 is being transmitted in the surgery. We sort of get the data from other viral infections like human papilloma virus, and we use the same data for precaution for the surgery in the COVID patient. So what is the risk of laparoscopic and the surgery and the gas and smoke evacuation? Is the laparoscopic surgery contraindicated? No, it is not contraindicated. If that is your routine practice during the laparoscopic surgery, keep on doing that. But you have to take a precaution for the gas and the smoke evacuation as if you do in the open surgery. Make sure that you use the filter smoke and filters for the smoke and the CO2, because the viral particles aerosolize. And all the COVID-19 patients, we have to follow strict guidelines for the smoke and the gas evacuation for all kinds of the surgery, even if it's open surgery, laparoscopic or endoscopy surgery. Now, what is the role of N95 respirator masks? This COVID-19, this virus, it can, N95 filter is very, very effective because of the physiology of the movement of the viral particles. All the positive patient on the investigation, symptomatic patient or questionable patient, we have to use the N95 respirator. If the patient is negative and asymptomatic, it is an option if you have N95 respirator or not. So then things come, how many times the N95 respirator can be used, because it's very hard to get the N95 nowadays. Without sterilization, you can use 5 times. With ultraviolet rays, you can use up to 10 times. Whenever you have to store the N95 respirator, you always be very careful. Keep it in the dry place. Make sure that the N95 mask is not touching any other objects, or you can put in a plastic bag. So what are the emergency devices that we should be using the operating room? Use as less as possible, because whenever you generate any smoke, sometimes the virus may aerosolize. And right now in the surgery, we don't know how the virus is getting transmitted, but we have to take all the complete precautions. Whenever you deflate the pneumoperitoneum, always use gas and the CO2 filter. Now once the patient's surgery is performed, like I said before, make sure that you don't mobilize the patient too much. You have to have a well-defined protocol for the inpatient care and the office follow-up. And in the office follow-up, sometimes you also can use the telemedicine. Now, we as a provider, we also have to take care of our family. So going home, what are the things that we should be careful so that our families are also safe? Many of the times I have seen the surgeon, they're staying in the hotel. When they work in the hospital where the high prevalence of COVID patient, they stay in the hotel. They don't go home because they want to take care of their family. Make sure that you use a hand sanitizer or disposable gloves whenever it's needed, whenever you touch ATM machine or whenever you touch any other objects. Even the cell phone, make sure that you take care of the cell phone well. Wipe it nicely, put whenever you're in the high risk environment, put that in the plastic bag. And many times once you go home, take your clothes and wash them properly upon arrival. Don't use the same clothes in the hospital and at home. Make sure that as soon as you go home, take it out. And avoid physical contact with a family member and wash the hand frequently. And also clean the surface at home with effective disinfectants, like a 60% alcohol. So these are the things that we should be careful at home. This ends my presentation, and stay safe. Thank you.
Okay, thank you, Sushil Dai, for your detailed presentation. Now I would like to invite Dr. Gupta. Sorry, Dr. Gupta had to kind of go back because he had a power outage. So he's going to finish his remaining presentation. So Dr. Gupta, please finish your presentation.
Yes, sorry for this. Like I was talking, like many of the cases are asymptomatic. Like one of the studies done in retrospectively in 34 patients, all patients those patients were in incubation period that was done in Wuhan. So all patients developed pneumonia shortly after the surgery, and nearly 50% of the cases they required admission to ICU, and 20% of them died after admission to ICU. So another case report is there which says like 4 of the cases which came to be positive after surgery, they all met with unexpected fatality in perioperative period. So serious it is. So that's why so many hospitals, they are lobbying for if you want to go for elective surgery, you have to go for preoperative test. Dr. Sushil told like it's a necessity. So Indian government also asked for the same. So, and though there may be a few resistance as to why all the cases should be undergoing universally this preoperative test, because negative results could make hospital staff more complacent, and they could avoid universal precautions. However, we have seen that so many cases are asymptomatic, so that has to be done. And cost factor is another one. So probably some solution will be there, like with a cheaper test availability to us. So with this, I would like to conclude my presentation by saying a few recommendations from a surgeon's side, like we should be able to triage patient, but that may depend on surgeon's perspective, like as to what is elective, what is semi-emergency, what is emergency. There may be different conditions. However, there should be like gradual resumption of the services according to local facilities and scenario of the local scenario, and universal precaution without any doubt should be practiced by all, and preoperative PCR test must be done in all cases if you want to avoid all healthcare workers and the surgeons getting infected with this disease. Thank you very much. Stay safe. Thank you.
Thank you. Thank you, all the speakers, for your time. Thank you. I would like to thank all the speakers for your time and effort to explain a very important topic to our viewers. We have several questions that have been posed to us. Many are interesting questions. So I would invite all of you in a panel discussion. And I would like to start those questions as they came in the web. So the first question is it ethical to make patient bear cost of N95 mask? So any of the presenter can answer the questions, or we can answer together.
I think, like, can you hear me, Bisna? I mean, it is not the ethical or unethical. It is like what is safe for the patient and the doctor. I don't think it's unethical for the patient to, bear the cost. If the hospital doesn't have sources, somebody has to buy it. So who's going to buy it?
So,
Like
Dr. Karki, any thought?
Oh, I think the question of ethics is where you have everything at your home place, and you are asking somebody to buy. But seeing the scenario in Nepal, I don't see any reason if the patient can buy. I think they should buy, because that's not for the doctors only, not for the health workers only. That's for them. Second thing, having said so, if possible, the service providers should get it, right? But the big question is how, when, and where in Nepal. So rather than this, whoever can should supply. I think we should answer it this way: whoever can should supply, whether it is the patient or the hospital, because either way down, we are concerned about safety of both sides.
Thank you, Dr. Karki and Dr. Pandey for your response. And the second interesting question is, Dr. Romeo asked the question. The question is, testing RDT or PCR, which one, the serological test versus PCR, which one should we recommend and why? And what type of PPE, and can we reuse PPE during the procedure?
The testing that we should be doing, and that is recommended, is PCR. Antibody, like whenever you do the antibody testing, it shows that you have been exposed, but it doesn't mean that you have an infection. You are a carrier. The antibody testing is only shows that you have been exposed, but the PCR is if you have a carrier. So all the patients should be doing the PCR. And for the PPE, one of the important things for the PPE is N95 masks. It's very hard to get it, and we should recycle it as much as possible. Recycling, it depends the method that you use for sterilization.
Okay. धन्यवाद सुशील दाई. अब मैले कुनै क्वेसन्सहरु चाहिँ नेपालीमा पनि सोध्छु, त्यो रिक्वेस्ट आयो है. त्यो कारणले गर्दा अब एक दुईटा अरु क्वेसनहरु चाहिँ म नेपालीमा सोध्दै छु. अब एकजना भ्युअरले सोध्नु भयो, इमर्जेन्सी सर्जरी गर्दाखेरि चाहिने व्हाट्स द रोल अफ टेस्टिङ? इमर्जेन्सी सर्जरीको केसमा चाहिँ के सबैलाई टेस्टिङ गर्नुपर्छ कि कसरी गर्ने भन्ने क्वेसन.
इमर्जेन्सी सर्जरी हामीले गर्नु पर्दैन. टेस्टिङ अब इमर्जेन्सी इज इमर्जेन्सी, इभन इफ द टेस्टिङ कम्स पोजिटिभ or नेगेटिभ, अपरेसन गर्नुपर्छ. त्यसको लागि टेस्टिङले गर्ने खास काम छैन. हामीले चाहिँ पेशेन्टलाई चाहिँ कोभिड पोजिटिभ छ भन्ने हिसाबले चाहिँ गर्नुपर्छ.
भनेको मतलब यदि इमर्जेन्सी सर्जरी गर्न पर्यो भने चाहिँ नै यो पेशेन्टलाई पोजिटिभ नै छ भन्ने मानेर सबै प्रिकसन्स लिएर गर्नु पर्यो.
गर्नुपर्छ.
Universal precaution.
ओके. अब त्यसैमा अर्को क्वेसन म जोड्छु. एकजना भ्युअरले सोध्नु भयो, युनिभर्सल प्रिकसन भनेको के हो कोभिड-19 को लागि भनेर सोध्नु भएको थियो. त्यसलाई पनि प्रस्ताइदिउँ न त.
The universal precaution is like, before the surgery, when the way like we discussed before, with all three presentation, whenever you move the patient in the hospital from one place to other place, whenever you intubate the patient, you take the precaution. Whenever you do the surgery, you do the precaution. Whenever you, after surgery, whenever you move the patient, you take a precaution. So there's a lot of factors that come in for the universal precaution for COVID-19.
धन्यवाद डाक्टर पाण्डे. र अर्को प्रश्न छ, सायद जोसुकैले पनि एन्सर गर्न सक्नुहुन्छ. यदि क्यान्सर सर्जरी गर्ने बेलामा कुनै पेशेन्टलाई क्यान्सर भयो र क्यान्सर सर्जरी गर्ने बेलामा चाहिँ नि के कस्ता प्रिकसन्सहरु अपनाउनु पर्छ त्यो क्यान्सरको पेशेन्टमा भनेर क्वेसन सोध्नु भएको छ. यो
क्यान्सर सर्जरीको केसमा के कस्तो प्रिकसन भन्दा बेसिकली क्यान्सर सर्जरी अरूभन्दा फरक होइन, र दुई तीन हिसाबले क्यान्सर सर्जरीमा फरक के छ भने, एउटा त टाइम होइन, तपाईँको अरू सर्जरी भन्दा धेरै क्यान्सर सर्जरी इज मोर टाइम टेकिङ. अब अर्को एज सच हामीले भनिराख्दाखेरि इम्युन कम्प्रोमाइजमा धेरै चान्स हुन्छ भन्दाखेरि, सिन्स द एक्सटेन्ट अफ सर्जरी र पेसेन्टको त्यो कन्डिसनले र स्टेज अफ डिजिजले पेसेन्ट अलिकति इम्युनिटी अथवा न्युट्रिसनल वाइज लो हुनसक्छ. अब त्यसपछि कुन पार्टको भनौँ न, जस्तो अब हामीले हेरेनेको अथवा लङ्सको उसको गऱ्यो भने दोज आर हाई रिस्क, जहाँ म्युकोजा हुन्छ होइन. र ओभरअल प्रिकसन लिने भनेको अघि डाक्टर सुशील दाईले भने जस्तो होइन, फ्रम पेसेन्ट इन्टरिङ द हस्पिटल टिल द पेसेन्ट गोज आउट अफ द हस्पिटल हामीले लिने प्रिकसन्स त्यही हो होइन. अब अलिकति हामी जस्तो डेभलपिङ कन्ट्रीमा ध्यान दिनुपर्ने कुराहरू भनेको ब्लड एभाइलेबल छ कि छैन, पेसेन्ट पार्टीले सबै कुरा बुझाएको छ कि छैन होइन. अब हामीले चाहिँ जुन गरिरहेको कोभिड टेस्टको रिजल्ट अहिले मैले नेगेटिभ भनेर गरिरहेको छु भने पेसेन्ट पार्टीलाई मैले बुझाउन सक्नु पर्यो कि यु माइट टर्न आउट टु बी पोजिटिभ होइन र अब कहीँ we might have to ask the patient हामीले चाहिँ तपाईलाई अल्टरनेटिभ थेरापी पनि they are like equivalently good होइन which might be of less risk to the patient and the hospital as a whole होइन त्यसको पनि अप्सनहरू चाहिँ हामीले उनीहरूलाई दिनु पर्यो।
धन्यवाद डाक्टर कार्की। र अर्को क्वेसन अलिकति हाम्रो जेनरल सर्जिकल लाइन भन्दा फरक खाले क्वेसन छ। त्यो क्वेसन चाहिँ इज इट पोसिबल टु म्यानेज टाइम फर डनिङ इन केस अफ इमर्जेन्सी सी सेक्सन भनेको इमर्जेन्सी सी सेक्सन गर्ने बेलामा चाहिँ हामीसित टाइम पुग्छ त डनिङ गर्नलाई त्यसको लागि कुनै अरू अल्टरनेटिभ्सहरू छ कि छैन भनेर सोध्नु भएको छ। अब त्यो अलिकति यो जेनरल सर्जिकल इरा भन्दा थोरै बाहिरको क्वेसन भयो। यसलाई कसरी एन्सर गर्ने होला? डाक्टर सुशील पाण्डे अथवा डाक्टर दिपेश गुप्ता हजुरहरूको केही सजेसन छ यसमा?
In case of even the emergency from the general surgery and the OBGYN is different. For OBGYN, even the 5 to 10 seconds make a lot of difference. So you do the best of your capability. If you can do it, that is the best. If you can do it, take up all the precautions. But the patient, your patient and the baby are the primary important, and if you have a time, do it.
Okay, धन्यवाद डाक्टर पाण्डे। अब मोटामोटी मेन क्वेसनहरु अरु चाहिँ रिपिट भएको जस्तो देखिन्छ हैन। अब एउटा क्वेसन चाहिने के छ भने when to advise radiological investigations for elective cases when PCR is available, after PCR or before PCR भनेर सोध्नु भएको छ। भनेको चाहिने appropriate timing of radiological investigations। अब कसरी टाइमिङ गर्ने रेडियोलोजिकल आवश्यकता परेको रेडियोलोजिकल इन्भेस्टिगेशन्स लाई बिफोर सर्जरी भन्ने क्वेसन छ।
So त्यसमा कुनै गाइडलाइन्स there is no such guideline as such. Again we are again talking about emergency cases, semi emergency cases or non emergency or elective cases. So whatever we can delay, we should always delay. यदि elective को रूपमा यदि हेर्ने हो भने त्यसलाई, if that is a real emergency, then you have to go for it without doing PCR also. Like because we are going for operations that is of high risk even. So why not to go for radiological services if that is a real emergency? But that has to be decided like by both of them. So that is a teamwork actually.
अरु कसैलाई कमेन्ट गर्नु छ यो क्वेसनमा? नत्र भने अर्को क्वेसन पनि यहाँ अलि राम्रो क्वेसन आएको छ यहाँ। So is it good to go for conservative treatment in emergency cases like acute appendicitis, acute calculus cholecystitis भनेर क्वेसन आएको छ, जेनरल सर्जरी खाले क्वेसन। यसमा सुशील दाइले केही भनिदिनुहुन्छ कि?
So you have to look at the patient and patient's history. So I'll give you the example. The patient is a diabetic patient. At appendicitis, if you want to do it sooner than later. Young, healthy patient with no medical problem, you can give the antibiotics, wait and watch. See if the patient immunosuppressed patient has to take a chemotherapy, has appendicitis, you have to do it early. You cannot wait. So it depends on a lot of factors. Depending same diagnosis, but different patient has a different outcome and different method of treatment.
Okay. धन्यवाद डाक्टर पाण्डे। अनि एउटा टेस्टिङ रिलेटेड क्वेसन छ, डाक्टर मल्लले सोध्नु भएको छ, एनी आइडिया अबाउट कमिङ अप टेस्ट दैट इज टेस्ट अफ एन्टिजेन इन इमर्जेन्सी केसेस भनेर। जस्तो अहिलेसम्म एन्टिबडी र पीसीआर टेस्टिङको कुरा भइरहेछ, अब एन्टिजेन टेस्टको पनि कुरा आइरहेछ, त्यो चाहिँ कुनै टेस्ट आइसक्यो भनेर सोध्नु भएको छ। जहाँसम्म मलाई लाग्छ त्यो छलफल त भइरहेको थियो, के अरे त्यो मलाई 100% स्योर भएन, तर आई थिंक इट्स अन द पाइपलाइन। यहाँहरुलाई केही थाहा छ यो बारेमा?
No, I don't know.
I read about it in like in RDT, whatever we are doing is antibody test, IgM, IgG, and then there are antigen tests also, that is RDT, that we are not doing. So there is no complete data as such. Just the swab layer, then we can go for antigen testing for that. That is also cumbersome, and that also has not shown to be a very good test as such. So, but things are coming up.
Okay. धन्यवाद डाक्टर गुप्ता। र यो एउटा क्वेसन हामीले प्रेजेन्टेसनमा डिस्कस त गरिसक्यौं, त्यही पनि यो क्वेसन फेरि मलाई सोध्न मन लाग्यो किन एउटा भ्युअरले सोध्नु भएको छ। किन आई थिंक दिस इज भेरी इम्पोर्टेन्ट क्वेसन जस्तो लाग्छ मलाई। व्हाट स्टेप्स विल बी टेकन इफ अ कोभिड पेशेन्ट or a suspected COVID patients and you haven't done the testing has to go for emergency surgery? So steps कसरी गर्ने फेरि बुझाइदिनु पर्यो। are we going to fumigate the OR every time a positive case come भनेर सोध्नु भएको छ डाक्टर पाण्डेले भनिदिनुहुन्छ कि यसको आन्सर
Yeah, sure. So if you have a patient who is highly suspected of having a COVID and you cannot do it, the first thing is like make sure that as soon as the patient comes to the hospital, keep the patient in a separate room. You need to have a separate room for the suspected or COVID patient in the hospital. Whenever you move from the one, even in the operating room, you need to have a separate operating room. That has to be close to the door. You cannot travel the patient a long way. And whenever you intubate the patient, make sure that all the staff in the OR, they go outside and try to intubate the negative pressure room. Once you finish intubation, wait for 10 to 20, around 20 minutes, and then the other staff can go inside. And whenever you do the surgery, whenever you do electrocautery, or if the smoke comes, make sure that you use the air filter or a smoke evacuator. It's very important. After surgery, you extubate the patient in the operating room and make sure that the patient recovers in the operating room. And from the operating room, the patient has to go to the ICU or the room, not in the post of care. So these are the things that we have to be careful.
Thank you, Dr. Pandey, for this clarification. Dr. Anil Daiलाई एउटा question सोधिएको छ, एउटा viewerले सोध्नु भएको छ, Anil Dai. Can you give us some idea about what do we mean by level 3 hospitals? What is the role? Are they only hospitals who should operate on positive cases? भनेर सोध्नु भएको छ. अनि फेरि if yes, then was that first COVID positive ENT case operated? If not, then has any COVID positive cases have been operated till now in Nepal? भनेर सोध्नु भएको छ.
Basically, your level 1, 2, 3 भन्ने चाहिँ Ministry of Health ले symptomatology र facility हेरेर divide गरेको हो. मेरो जानकारी अनुसार level 1 is where you keep all these asymptomatic patients. Level 2 with minimal symptoms, and if required, you have ICU facilities. And level 3 say you have multi-specialty care भन्ने उहाँहरुको चाहिँ एउटा कन्सेप्ट हो. सरसर्ती भन्दा जस्तो level 1 मा अहिले कोरोना स्पेशल भनेर खोलिएका अस्पतालहरु छन् हैन. लेभल 2 मा डिफरेन्ट सिटीमा भएको मल्टी स्पेशलिटी केयर भएको आईसीयू सेटअप सब भएको हस्पिटलहरु छन् भने लेभल 3 मा आई थिंक दे हैव स्पेसिफाइड 3 हस्पिटल्स टिल नाउ. टिचिङ हस्पिटल, धरान र नेपालगञ्ज हैन. मेरो जानकारी हो अनुसार त्यो भन्दा कुनै पुरै जस्तो लाग्दैन. अब लेभल 3 को कन्सेप्टमा यु हैव अ कार्डियोथोरासिक टिम, यु हैव मतलब ICU team, neuro team, everything भन्ने हो. Positive case, as far as I know, hasn't been operated. There was a patient, I think, in IOM only, TUTH, which turned out to be positive. I'm not sure whether she was planned for surgery or she was kept. She was patient of ENT. To मलाई थाहा छ हैन. Then till date कुनै पनि पोजिटिभ पेशेन्ट पीसीआर पोजिटिभ भएर सर्जरी भएको भन्ने चाहिँ मिनिस्ट्री अफ हेल्थको डाटाबाट आएको छैन. र आईसीयूमा भएको पेशेन्ट पोजिटिभ भएको भने चाहिँ क्रिम्सनमा एकजना पेशेन्ट हु इज बीन ट्रिटेड फर आई थिंक जन्डिस स्टिल इन द आईसीयू हैन. तर पोजिटिभ र अपरेटेड चाहिँ अहिलेसम्म मेरो जानकारीमा मलाई थाहा छैन.
धन्यवाद डाक्टर कार्की. डाक्टर कार्कीलाई नै अर्को क्वेसन छ, भेरी समसामयिक क्वेसन छ डाक्टर कार्की. अब नेपालको परिप्रेक्ष्यमा हेर्दाखेरि अब यो पीपीई को कस्ट, टेस्टिङ को कस्ट, रिस्टरलाइजेसन अफ सर्जिकल गाउनको मोटामोटी कस्ट कति हुन्छ, कसरी यो कस्टलाई जोगाड गर्ने, कसरी कस्ट इफेक्टिभ हुने भन्ने कुरो सोधिया छ.
दुई तीनवटा कुरा हो. एउटा त अब इफ यु हैव फ्यासिलिटी कोभिड पोजिटिभै छ अथवा यु आर अपरेटिङ अन इमर्जेन्सी पेशेन्ट विच कोभिड स्ट्याटस यु डोन्ट नो, र तपाईले चाहिँ यसलाई कोभिड पोजिटिभै मानेर गर्नु छ भने it's very mandatory you have a standard PPE. अब त्यसपछि रह्यो अब नेपालको कन्टेक्स्टमा पाइँदै पाइँदैन हैन. र हामी अहिले अब भनौं न गाउँ गाउँमा सीएस गरिराछौं, एपेन्डिक्स गरिराछौं, एक्टोपिक गरिराछौं भने अब लोकली आफूले कसरी प्रिभेन्ट गर्न सकिन्छ. जस्तो एटलिस्ट भित्र चाहिँ प्लास्टिक शीट राखेर जुन हामीले इन्डोस्कोपीहरुमा उहरुमा युज गर्छौं, फेस शिल्ड बनाएर हैन डाइरेक्टली कन्ट्याक्ट हुने. र अब रियुज गर्ने त हामीसँग अटोक्लेभ गाउन जुन छ हैन. अब त्यही नै र जुन ड्रेपहरु हामीले नेपालमा युजली गरेका छौं त्यसलाई चाहिँ प्रपर सेफ्टी मेजर लिएर धुने गर्ने र चाहिँ त्यसलाई अटोक्लेभ गर्ने बाहेक हामीसँग अरू अप्सन छैन।
ओके, धन्यवाद डाक्टर कार्की। त्यहाँ अरू पनि क्वेसनहरू आउने क्रम, यो एकदम इन्ट्रेस्टिङ टपिक जस्तो छ, सबैलाई एकदम इन्ट्रेस्ट जागे जस्तो छ। क्वेसनहरू नन स्टप आइरहेको छ र हामी सबै क्वेसनहरूको एन्सर दिने कोसिसमा छौँ। सायद दिस विल बी हेल्पफुल फर अल द भ्युवर्स टु क्लियर द डाउट, एन्ड थ्याङ्क यू फर वाचिङ। सो अर्को क्वेसन छ, अब नेपालमा सुनिन्छ नि, जस्तै एउटा केस हस्पिटलमा भेटियो, पुरै हस्पिटल सेल गर्ने, त्यो के ठिक हो? पुरै हस्पिटल सिल गर्न अथवा त्यसका उपायहरू के छन्? टेम्पोररी चाहिने, अब त्यसलाई चाहिँ क्लिन आउट गरेर चाहिँ फेरि सेवा सुचारू गर्ने हो कि यसरी झ्याप हस्पिटल बन्द गर्दा त समस्या देखिने भयो नि त भन्ने क्वेसन छ। त्यो अनिल दाइले एन्सर गर्नु पर्ला अथवा दिपेशजीले।
Okay, so that was the concern actually. Pre-operative counseling, pre-operative testहरू गर्ने एउटा जुन concern थियो. Even people are coming up with admission, even any admission to the hospital that should be tested at all. सुरुमै गर्नुपर्छ भन्ने जुन कन्सेप्ट आएको छ. So that is for this only. नत्र भने एउटा पोजिटिभ आउने बित्तिकै सबै सिल गर्ने अवस्था आउने, like we saw in TUTS, like we saw in Dhulikhel, that went on. So is that right or is that wrong भन्ने कुरा त एउटा कमिटीले डिसाइड गर्ने कुरा हो. Like for example in Dhulikhel, what happened? इमर्जेन्सीमा आएपछि that came out to be positive, then probably that could have been, for the timing, that could have been sealed, and that is what they did. And then again that could be open for after some time, after taking few temporary measures. That could be done. From completely, like in teaching, what happened, like what I heard from my resource, from my friend, that even other surgeons like neurosurgical team, they were sent for quarantine because they used to be in the same ward. So even the neurosurgery team was sent for quarantine after that patient came out to be positive. So that was very unfortunate actually. So that's why these all tests are important. Is that right or wrong? त्यो हामीले अब इन्फेक्सन प्रिभेन्सन कमिटीले डिसाइड गर्ने कुरा हो. हस्पिटलको सिनारियो हेरेर what was the condition, like what could have been the effect of that patient being there for how long, यही सबै कुराहरू.
धन्यवाद डाक्टर दिपेश जी। फेरि अर्को क्वेसन त्यसैमा के थपिया छ भने, यो पिपिई चाहिँ 6 देखि 8 घण्टालाई मात्रै इफेक्टिभ हुन्छ भन्ने सुन्या छ। what to do for long hour surgery भन्ने क्वेसन आएको छ। डाक्टर सुशील यसलाई केही क्लियरिफिकेसन गरिदिनुहुन्छ कि?
I think like most of the surgery is from 6 to 8 hours, and there are very, very few surgery more than 8 hours, 6 hours. So I think like, should be, there's no any guideline for that. After you take care of one patient and when you go to the next patient, make sure you take out everything. For the same patient, there's no guideline. I think it's okay to use. If you have it, you can change it, but otherwise, you can use the same one.
Thank you. यो अर्को क्वेसन फेरि यही प्रोसेससँग सम्बन्धित क्वेसन छ। जस्तो we have patients who are mostly asymptomatic and mostly without PCR done, and we have OR which are all modular with positive pressure and HEPA filter is blocked without air conditioning. How can it be modified? यो कसरी मोडिफाई गर्न सकिन्छ भन्ने प्रश्न छ। अब त्यो चाहिने अब अलि अप्ठ्यारो क्वेसन छ, तर अब डाक्टर कार्की, डाक्टर गुप्ता, डाक्टर पाण्डे जोले गरे पनि हुन्छ यो एन्सर चाहिँ।
Yes, probably
मलाई I think यो सुशील दाइले हामी भन्दा राम्रो एन्सर गर्न सक्नुहुन्छ कि, because this was like never a big problem in Nepal before. So हाम्रो experience or expertise अलिक पुग्दैन कि?
So, intubation and the extubation has to be done in the negative pressure room. So if you have it, then use the negative pressure room, then transfer the patient to the OR that has a positive pressure room. And if you don't have, negative pressure room, so you need to be very, very careful whenever you, intubate the patient. And many times, anesthesiologists, they change the techniques. They have a barrier between the patient and the doctor. In fact, many of the time they have the plastic sleeve that they can intubate with all the glass and the face masks. So that is a difficult situation, but you have to be extremely careful because you have to take care of the patient. And if you don't have a negative pressure room, do everything possible so that you don't get it or you don't transfer to the patient, other people.
अथवा यदि सबैलाई चाहिँ पोजिटिभ मानेर सबै फुल पिपी लाउनु पर्यो जुन चाहिँ अवेलेबल छ भने, हैन त?
That's right, yeah.
Intubation usma the aerosol box could be a better alternative.
Yeah.
how safe
Yeah.
that can be, but we can do that. And of course, during surgery, get the best protection you can have. So we are at least anesthesiologists, OT को टिमहरूलाई पनि I encourage them to use face shield and all. कि डाइरेक्ट त्यो कन्ट्याक्टमा नहोस् होइन अनि अब if you can intubate from maintaining the distance as far as possible होइन अब अहिले चाहिँ जस्तो काठमाडौँमा चाहिँ केही डाक्टर साहबहरूले त्यो फाइबर अप्टिक गरेर भिडियो ल्यारिङ्गोस्कोप पनि डिजाइन गर्नुभएको छ सो आई थिङ्क दिज आर द अप्सन्स वी हेभ र अब यो जुन अघि सिलको कुरा छ अब सिल चाहिँ सकिन्छ भने एउटा फ्लोर एउटा रुम फर सर्टेन पिरियड टिल ऊ सिल गर्नु नै बेटर होला अब यसरी दिनदिनै एउटा हस्पिटल दुईवटा हस्पिटल गऱ्यो भने त एट द एन्ड लाइक नन कोभिड चाहिँ कहाँ लगेर हेर्ने भने जस्तो सिनियर पनि आउन सक्छ होइन जुन अहिले अब नेपालमा एउटा आई डोन्ट नो कताबाट रेकमेन्डेसन हो एउटा केस पोजिटिभ भेट्यो भने फलानु हस्पिटल सिल फलानु यो सिल भनेर मिडियामा एभ्री डे इट्स कमिङ होइन त्योभन्दा आई थिङ्क बेस्ट चाहिँ त्यहाँको अरूलाई पनि टेस्ट गर्ने र सर्टेन एरिया जहाँ पेसेन्ट म्याक्सिमम छ जस्तो आइसियु होला अथवा त्यो होला त्यो एरियालाई चाहिँ फ्युमिगेट नगरुन्जेलसम्म सिल गर्ने होला होइन भने त भोलि साँच्चै नै सर्भिस दिने ठाउँै पनि रहन्छ जस्तो लाग्दैन
धन्यवाद डाक्टर कार्की
Who makes the decision? Who makes this decision? Is the doctor or committee or politician or?
Meaning sealing the hospital.
हजुर
No, who? Yeah.
I don't
Who
know.
makes the decision?
As far as I know, अब जस्तो भरतपुरमा we had 2 asymptomatic positive cases, होइन. That time चाहिँ all of us were involved, so we sealed a floor only. एउटा फ्लोरमा हामीले आइसियु सहितको भरतपुर हस्पिटलमा त्यहाँको मेडिकल सुपरिन्टेन्डेन्ट फिजिसियनदेखि लिएर लोकल भनौँ न पोलिटिकल पार्टी एडमिनिस्ट्रेसन बसेर ओके दिस इज द कोभिड एरिया भनेर त्यो एउटा फ्लोर मात्रै सिल गरेको हो जहाँ पेसेन्ट थियो अरू सर्भिस हामीले उनी गरेका थियौँ सिन्स द पेसेन्ट वेयर एसिम्टोमेटिक वी म्यानेज एभ्रिथिङ नट अब अहिले यो अरू जुन हस्पिटल सिल गर्ने भनेको चाहिँ आई फिल इट्स लाइक लोकल एडमिनिस्ट्रेसन र लोकल पब्लिक मतलब लिडर्सकै धेरै रोल छ जस्तो लाग्छ मलाई किनभने देयर आर मल्टिपल बिल्डिङ्स र हामीले चाहिँ एउटा बिल्डिङको एउटा फ्लोर मात्रै सिल गरेर अरू चाहिँ भरतपुर हस्पिटलको सर्भिस चाहिँ रिज्युम भएको थियो अब नेपालगञ्जमा के छ डाक्टर दिपेशलाई आइडिया होला किन अहिले त हट जोन नेपालगञ्ज छ
Everywhere there is a committee, there's a core committee बनाएका छन् जिल्ला प्रशासन कार्यालय सहित जुन सरकारी निकायहरू छन् so probably they are deciding probably त्यो हुन सक्छ
मेरो एउटा यसमा चाहिँ नि अब हाम्रो अनुभव यताको अनुभव भन्दाखेरि चाहिँ हरेक हस्पिटलमा एउटा डेडिकेटेड फ्लोर र डेडिकेटेड रुमहरूलाई चाहिँ कोभिड युनिट भनेर छुट्याइएको हुन्छ अनि त्यसमा चाहिँ नि मान्छेको मुभमेन्टहरू कम गराउने र यदि अपरेसनमा गर्नु पर्यो भने सर्टेस्ट डिस्टेन्स पोसिबल फ्रम द्याट प्लेस टु द ओआर गर्ने गरेर छुट्याएपछि के हुन्छ भने कोभिडको बिरामीहरू त्यहीँ आउँछन् त्यहीँ टेक केयर हुन्छन् र त्यो भएपछि चाहिँ बाँकी रहेको फ्लोरहरू चाहिने मा चाहिने नन कोभिड पेसेन्ट्सहरूको चाहिँ सेवा प्रदान गर्न सकियो त्यो भएपछि एक किसिमको कस्तो हुन्छ भने हस्पिटलै बन्द गरिहाल्नुपर्ने स्थिति चाहिँ नरहला भन्ने त्यो एउटा धारणा त्यसरी चाहिँ हामीले यहाँ प्र्याक्टिस गर्छौँ सबै हस्पिटलहरूमा
And that may be according to local scenario, local hospital. Like we have 2 hospitals, one is very big, one is a small one, congested. So according to the local situation, probably that should be decided. कुन चाहिँ dedicated COVID hospital बनाउने के गर्ने भनेर taking all safety measures.
अर्को क्वेसन सोधौँ है त मैले यहाँ यो चाहिने
बिफोर फिनिशिङ द यो सिलको क्वेसन अहिले यो सिल गर्छ भन्ने कारणले अर्को नेपालमा नेगेटिभली के सुरु भइरहेछ भने पिपल बिन हेजिटेटिङ टु टेस्ट
अच्छा ओके
हैन यो धेरै सेन्टरहरुबाट हामीलाई त्यो खालको साथीभाइहरुबाट आइराछ कि सर दाइ साथीभाइले कि हाम्रो यहाँ टेस्टै गर्न पठाउन मानिरहेछ छैन किन भन्दा यो अब as part of service हैन अब र यहाँको जो एम्प्लोयर होला अथवा लगानीकर्ता होला अथवा के होला भनौँ न हैन लाई एउटा डर के भने भोलि मैले टेस्ट गरेर या मेरो हस्पिटलमा अथवा मेरो केमा पोजिटिभ आइदियो भने सिल गरिदिन्छ एडमिनिस्ट्रेसनले भन्ने डरले पनि पिसिआर टेस्टिङ गर्न नपठाएको अथवा पठाउन हिचकिचाएको भन्ने खालको कुरा आइरहेछ। त्यही भएर साइन्टिफिक पार्ट इज लाइक एउटा फ्लोर होला अथवा एउटा सेक्सन होला होइन, र सकभर त्यही फ्लोरमा सबै फेसिलिटी छ भने वेल एन्ड गुड, छैन भने पनि नियरेस्ट एक्जिट गरेर गयो भने राम्रो पनि होला। होइन भने अब यसरी यो ऱ्यान्डमली अब यो त कस्तो भयो भने यो ह्याभोक कस्तो भयो भने बाटोमा बाँस तेर्साउनेदेखि लिएर हस्पिटल सिल गर्नेसम्मले एउटा वी आर क्रिएटिङ अ बिग ह्याभोक के, विच इज लाइक भोलि नर्मल्ली भनौँ न नर्मल मेडिकल फेसिलिटी पनि कहाँबाट दिने भन्ने बिग क्वेसन आउँछ कि यसले।
धन्यवाद डाक्टर कार्की। एउटा क्वेसन फेरि अर्को आयो, हेल्थ केयर वर्कर इन्भल्भ इन इमर्जेन्सी सर्जरी फर एनी सस्पेक्टेड केसेस, आर दे सपोज टु अन्डरगो कोभिड टेस्टिङ विथ एभ्री केस? Dr. Sushil Rai?
No, I don't think it's necessary. All you do is like take the maximum precaution.
Actually, I agree with that, because otherwise we would all be testing ourselves every day.
Every day.
So अब अर्को क्वेसन्स छ, अझै एक दुईटा क्वेसन बाँकी छ। Dr. Pragya from Nepalganj सोध्नुहुन्छ, how are we sending the post-operative specimens to the laboratory? Any counseling to the carrier? Should PCR positive patient be transported to COVID specified hospital? भनेर सोध्नु भएको छ।
पोस्ट अपरेटिभ स्पेसमेन ह्यान्डल गर्दा त आई फिल लाइक पर्सन सुड एटलिस्ट ह्याभ ग्लोभ्सहरू लिएर जानु पर्यो। अब इफ इट इज अ हिस्टोप्याथोलोजी स्पेसमेन मिनिमम स्पिलेज फर्मालिनहरूको कन्ट्याक्टमा आउने गरी होइन। अब नेपालमा चाहिँ प्लेसेस अनुसार यो डिफ्रेन्ट ट्रेन छ, कहीँ भिजिटरलाई दिने ट्रेन छ, कहीँ चाहिँ हस्पिटलकै स्टाफले लिएर जाने ट्रेन छ होइन। सो एटलिस्ट डिपेन्ड्स। अब इभन इफ इट इज अ भिजिटर उसलाई चाहिँ प्रपर एउटा इन्स्ट्रक्सन, तिमीले चाहिँ फुल स्लिभ लुगा लाउनु पर्नेदेखि ग्लोभ्स लाउनु पर्नेदेखि वी क्यान एटलिस्ट एउटा चाहिँ डिस्पोजेबल ग्राउन्ड लाएर त्यहाँसम्म पुर्याएर होइन, तिमीले त्यो छोडेपछि हातहरू राम्ररी धोएर लुगाहरू गरेर आऊ भनेर चाहिँ एटलिस्ट वी सुड इन्स्ट्रक्ट द्याट एन्ड वी हेभ बिन डुइङ द्याट। अब बाहिरको के छ आई डोन्ट नो।
Actually, okay, so obviously pathology department, they will be taking care of all those precautions they should be and must be taking. So body fluids, I went into literature to see like what are the body fluids that may be carrying this virus. So as far as literature is concerned, they say like body fluids, it has been seen in ascitic fluid and feces especially. So most of the papers, they state that. But other than that, there are controversial things that whether it has been seen in urine even. So one paper says, no, it has not been seen in FAR, and another paper states, yeah, it has been seen. So incomplete literature is there. So it is still evolving. So is there any presence of that thing in the body, another body part of the specimen that is still coming up? Probably later on, we will be having all those literature. Universal precaution. We have to think that it is there, and we have to counsel accordingly.
I think I agree, Dr. Dipesh. So your clarification, Dr. Balaram Malla has clarified that Dhulikhel Hospital closed only for ER fumigation and disinfection. Media told hospital was sealed, which was not true. लगभग सबै क्वेशन्सहरुको आन्सर सकियो। यहाँ अब नयाँ क्वेशन आउने क्रममा छैन। I would like to thank all the speakers for your precious time. I would like to thank all the viewers for your precious time. This presentation will be recorded, so it's available for you to review for the future. And ANM of Nepal, in collaboration with NMA and NMSS, will be hosting many more of these webinars that are relevant to current COVID-19 pandemics in Nepal. Our goal here is to basically alleviate the fear, to share the knowledge rather than to dictate anything, because every place has their own priorities and own limitations. So these kind of discussions, we think, would help in at least moving forward for safer management of our patients. Once again, I would like to thank you, everyone, and have a good night in Nepal and good afternoon from USA. Namaste.
Thank you, Vishnu. Thank you very much. Anil, thank you.
Thank you, Sujil Lai. Thank you,
Dr. Dipesh, thank you.
And I would like to thank Dr. Santosh Sapkota for helping us out all on this technical aspect today. Without him, we could not have been able to do this.
Thank you, Vishnu. And I would just like to add a small comment here. So those speakers who are on Facebook, please go ahead and review some of these questions if you have missed it.
And Dr. Bhupesh Khadka, our president, thank you for helping me out on the question part. And please say something from your side.
Thank you, Vishnu. एकदम राम्रो प्रेजेन्टेसन भयो. आई थिंक द नीड अफ द आवर चाहिँ प्रत्येक हस्पिटलहरुमा एउटा इन्सिडेन्ट कमान्ड सेन्टर बनाउने, त्यो हस्पिटलको मान्छे बिरामी आउँदाखेरि बिरामी कुरुवाले के गर्ने, त्यसपछि के भन्छ स्टाफले के गर्ने, नर्सले के गर्ने, डाक्टरले के गर्ने, कति समयमा चाहिँ त्यो डिसइन्फेक्टेन्टले चाहिँ सर्फेसहरु क्लिन गर्ने भन्ने कुराहरुबाट हामीले सुरु गर्यो भने यो एउटा प्रोटोकल, एउटा पोलिसी जस्तो बनाउन सक्यौं प्रत्येक हस्पिटलमा भने आई थिंक लट अफ दिस क्वेशन्स अबाउट सिलिङ अनि मान्छेको ट्रान्सफर कसरी गर्ने पेशेन्ट्सहरुको त्यो कुराहरु चाहिँ एड्रेस गर्न सकिन्थ्यो होला. त्यो चाहिँ हाम्रो अमेरिकाको चाहिँ धेरैवटा हस्पिटल, प्राय हस्पिटलमा सबैमा इन्सिडेन्ट कमान्ड सेन्टर र चाहिँ त्यो प्रोटोकलहरु भएको हुनाले धेरै सजिलो भएको छ. अब भिजिटर पोलिसी देखि लिएर ओपीडीमा मान्छे आउनेदेखि लिएर सबै व्यवस्थापन गर्नलाई चाहिँ त्यो इन्सिडेन्ट कमान्ड सेन्टर एउटा हस्पिटलमा आफ्नो इन्सिडेन्ट कमान्ड सेन्टर भयो भने त्यो पोलिसी बनायो भने चाहिँ आई थिंक इट विल बी भेरी हेल्पफुल जस्तो लाग्छ है.
It's a very important point.
हाम्रो हस्पिटलमा चाहिँ एउटा कोर कमिटी बनाएर, so we worked on that. And we have come up with a guideline, short guideline or protocol, whatever you say, ki OPD start garda athwa certain kurarma how to go about that, what to do in each state. So our management has also worked very hard to follow all that protocol.
भूपेन्द्र दाई हुनुहुन्छ भने केही कमेन्ट गर्नु होला, नत्र म बिदा हुन्छु यहाँबाट.
Thank you all the presenter and all who are listening it. We will continue. हामी यो चाहिँ प्रोग्रामलाई कन्टिन्यू गर्छौं, फेरि पनि सबै यो सूचनालाई अगाडि बढाउँछौं. धन्यवाद.
Thank you everyone. Good night.
Thank you. Good night. Bye bye. Thank you.